England as well. I think you do most of the intravitreal here.
Are you guys using antibiotics post injection, Dr. Safdar?
No, we don't.
No, not anymore now. Yeah. Even
Even
no pre-op, no post-op either.
There's a number of reasons. I think by the time the patient comes here, the horse is, as they say, already bolted. It's too late. So you have to treat is whatever you can get your hands on. I think that the battle you can win is well before that. And identify the risk factors, and you not going to go through them like nephritis and stuff like that. But patients even in UK do very funny things. They will rub the eyes, and the little old ladies, they're fascinating in my area where I work, and they do all sorts of things. I've even sort of patients don't like the drapes. I've sort of even injected people just with they don't want iodine. So I think the crucial bit is really the 5% of iodine. I think that's the crucial bit. If it sticks on the eye for about 2 minutes or so, 90 seconds, I think that's pretty much good enough. If they are clearly allergic to that, they develop a sensitivity to that, you can try chlorhexidine. I think it's available now in 0.1% or 0.02%. That's available as well. I mean, we have a completely nurse-led delivered or nurse-delivered injection service for the last, I would say, 10, 12 years now. We do about 8,000 injections a year for various nice indicated indications now. One thing about intravitreals is that I do remember the steroids. They have a high risk of endophthalmitis, so you have to be a bit more careful and counsel and consent the patient accordingly. And probably it's an exam question as well. If I'm your examiner, I'm going to ask you that whoever is sitting here. So these are the sort of things. But I think in view of the management of endophthalmitis, I don't think there's going to be much variation. Post-operatively, we don't use the drops anymore.
Still suggest first injections. No need for going directly to vitrectomy, and just do intravitreal antibiotics first.
Yeah, I know.
And then if it doesn't improve, then refer to your colleague.
I mean, I know the moderator is a VR surgeon, but medical retina people have their uses as well, I suppose. I think it depends on the level of vision. Yes. Only eye, what is the status of the other eye, and patient's lifestyle as well.
Yeah, but I think approach is similar as we're talking about. Intravitreal antibiotics is the must thing, first thing you need to.
I think it's if you know how to put in a trocar and a 23 gauge cutter, you can get a very nice sample as well. I used to do VR once upon a time, but I don't do it anymore.
Dr. Ahmed, what about your prophylactic? Do you give antibiotics pre-op, post-op? What happens in Egypt?
Yeah, we know that antibiotics pre-operatively or post-operatively does not have any role. Even it may increase the resistance of the organism to antibiotics. But
so
in Egypt we give
any antibiotics.
No, but in Egypt we give. Because I'm afraid.
How many days? How many days?
For 5 days.
5 days.
Because I'm afraid that if the patient developed endophthalmitis, you might tell me, you didn't give me an antibiotic. That's why I got an endophthalmitis.
Somebody is going to sue you if not given antibiotics.
So I give antibiotics pre-operatively and post-operatively.
Gustavo, what about you in Brazil? Do you give prophylactic antibiotics pre-injection or post-injection?
So I was laughing together with Rashdi because when I started, of course, I would give drops for 5-7 days, and patients feel safer when you give them drops. When the paper showing that not giving antibiotics was safer than giving them, I stopped using. I had so many patients wanting a consultation with me to explain why I was not giving them drops. So I had to explain the paper for my patients. Yes. It took me like half a year to convince them that they didn't need the drops. Nowadays, we don't use anything. The only prophylaxis we do is iodine povidone 30 seconds before the injection, or at least the region where we are going to inject, okay? And since then, hopefully we haven't had any infection, but you have shown us an extreme case, okay? Since the entrance spot compared with the phaco, it's much smaller, you don't have the same charge of bacteria, okay? But usually you can solve it with injections. You don't have to go to vitrectomy. And I think it works perfectly. One issue we have here, it's a big concern. Most of my patients come from, or at least half of the patients, live like 200 or 300 kilometers apart from our clinic. And these patients, of course, you have to inject both eyes, okay? So never from the same vial, okay? Otherwise, if you have an accident like that on both eyes, it will be a disaster.
Yeah, that's I think true. Yeah.
And you can also, you cannot also make this patient come every 15 days because it's too expensive for them.
Yes. Rahman, you want to add, or Zubaida?
I was just going to say that I use the antibiotics as a lubricant. So, you know, a lot of patients have complained with the povidone iodine because the eye is irritable. So I give them 4 times a day, and if they complain, I tell them already that, you know, agar aapke aankh mein problem ho raha, just use it every hour.
Okay.
And it's more as
just
a
for
lubrication.
4 or 5 days you do?
Yes, 4 or 5 days.
But no pre-op, you don't
No,
use,
I
because
don't
some
use
people still
anything.
use, and I know the colleagues who use tablets as well.
Yes,
Oral
yes.
antibiotics, people are
Yes,
still using
so
it.
every month they take oral antibiotic course, and then they
Yes.
take drops course. But
Yeah.
you know, I just use it as a psychological thing, as in Egypt. So I don't want to be blamed that for not giving antibiotic, you know, they have any problem. And mostly it's actually preservative-free antibiotics such as moxifloxacin. So if they have a problem, they can use it as a lubricant as well.
Zubaida?
Thank you, Dr. Rahman. So in doubling where I was being trained, they would give pyridine iodine prior to giving injection, like while the patients were waiting in the clinic. We'll just put 1 drop of pyridine iodine along with moxifloxacin, 1 drop, and there were a few consultants who would insist on giving, post intravitreal injection antibiotic as well for 4 or 5 days. And another comment I would like to add is there have been studies which show that the culture, mostly in the post intravitreal endophthalmitis, the culture would be streptococci. There's the aerosolized flora, the mouth flora. So we really need to, cover our face before giving injection.
I think it's a very important point to wear the mask. Absolutely. So that's important thing. I think caps and other things may not, but mask is that right? Mask is even UK, or you don't wear masks?
I think mask is an interesting one, because we used to wear that, and then we
Yes.
stopped it altogether for many years.
Yes.
And then COVID came, and we went back to the mask now,
Yes.
and then it started to come
Yeah.
off again. So it's a bit of that. Well, I think there was a study from John Hopkins or somewhere about a few years back, where they showed that if you speak, I think that proper culture, the agar place, and all of that stuff, they did that. I don't know how sort of if you properly critique the study, whether how well it is that, but they actually showed, and there are a very huge number of patients in there, that actually if you, the minimum amount of speaking used during the injection, that is what matters. So you shouldn't really be saying, and we used to chat with our patients all the time, but our rates were no different. So I don't know there must be something in the air everywhere different, and how it works, I suppose. But the mask is purely because I think it's a COVID legacy now over there, rather than purely needing it from the injection point of view. And even now, the cataract surgery as well, we are trying to move away from that now.
So traumatic endophthalmitis, I think, let's move. Sorry, you want to add, Dr. Shakib? about something?
I think I am the one you were mentioning that there are some doctors who are still using tablets also. So
Sorry, I didn't know that.
because I don't play brave
No,
in
but I
this
know.
thing.
Yeah.
So my practice is that when the patient comes to me for at least 15 minutes, every 5 minutes or 4 minutes, he gets a drop of antibiotic in the waiting room, drops. And then some local, proparacaine, and then I inject under the microscope in the operating theatre. And then I give 1 500 milligrams ciprofloxacin an hour before and 1, say, after 12 hours. I tell him take 2 tablets, 1 before and 1 after. And I also give antibiotic drops for a few days, antibiotics and steroid combination for a few days. Just follow. And so I don't play very brave in our situations because
No, but
Do you have any shares in the antibiotic industry or no?
with this approximate.
I know some people who give for 1 week tablets.
I think Hina wanted to say something.
Yes, Hina, please.
When you have post-injection,
Mic to dein kindly, Dr. Sahib. I think it would be better, everybody can hear.
I presume I'm loud enough.
No, you are not loud.
So when you have post-injection, and there are studies to back this up, that it's actually more florid and more aggressive because the portal of entry that is now sealed, it just leads to more of nastiness within the vitreous cavity. So I do also have a low threshold of taking this patient to my VR surgeon for a vitrectomy, because most of these patients enjoy relatively good vision. And when they're left with those kind of floaters, that even if you treat with intravitreal antibiotics, they're left with that kind of floaters, and they're very, very annoying patients to come back to you. They keep coming back to you कि ये तो मुझे पहले नज़र नहीं आते थे. तो अब आप उसको कैसे समझाओ कि भाई जहाँ से आपको वापस लेके आए हैं, जहाँ आप जा रहे थे, तो वहाँ भी अल्लाह का बड़ा कर देता हूँ, but that floaters, they stay, and therefore the patient stays in your clinic. And so if I have to go, because of the aggressiveness of the disease, I do have a lower threshold. So I've had one endophthalmitis, acute post-injection endophthalmitis case in 6 or 7 years. I will not advocate not using antibiotics, even though we won't have enough evidence of that. But if we do have evidence
You mean
of
topical or
topical antibiotics in Pakistan, because if we are to swab our OTs and to swab our the commensals in our patients and swab everything else, what I do, and I feel like is a good trick, is and what I learned from my consultant in the UK was, if you just retract the conjunctiva before you inject, so as the conjunctiva goes back, it kind of forms a natural bandage, natural barrier to your site of entry actually, and it gives like a longer route for the commensals to actually reach the vitreous cavity, and I think that really helps. Povidone iodine really helps. Everyone has a different time. Mine is about 45 to 50 seconds, and plus there is installation of Halcyon povidone iodine while the patient is being ushered into the OT and doing that list, and I think that really helps. So there was that outbreak in Tennessee, I think that's the one you were talking about 4 endophthalmitis cases, and they traced it back to the dispenser in the pharmacy not wearing a mask and talking to his colleague while he was preparing the injection. So there is evidence. I don't know, I haven't critiqued that article yet, but that was the conclusion to that article. So yes, I do advocate that everybody in my OT should be wearing a mask.
In our circumstances, yes, I
Yeah, I
agree.
think it is, yeah. But traumatic
It's,
endophthalmitis.
I think that is an important point, but when you are doing your injections, I think there is a specification of your operating room or a clean office. I think there has to be a certain number of air exchanges. I think the minimum for intravitreal injection in UK is 10 airflow exchanges. For a cataract operation, it should not be less than 25. So I think as long as you got that airflow exchange and everybody else is behaving, that should be okay.
Any one of us doing in office injections here? In office means in your clinical room, जहाँ patient को देखा है, you're injecting. Clean room is different thing. What I'm talking in office means that you examine the patient same room. I think US people do. Anyone in Pakistan does, Gustavo, and in office injections, or do you do in clean room or theater?
No, in Brazil it's forbidden. You have to do in the OP room.
Same.
It's a pity because you lose a lot of time and increases the costs. Okay, so you have to take a whole morning or a whole afternoon to do the injections. And I think our offices are clean enough and safe enough to do the injections inside it.
Right. Okay. I think
I look at it, but the way is do a mother test and a mother-in-law test. If my mother is getting injected, I want a clean office, and my mother-in-law, I don't care. And that's an easy way to remember.
Interesting. Okay. Traumatic endophthalmitis. I think, Rahman, if patient comes to you, there is a trauma, maybe not intraocular foreign body, some thorn went into the eye or something happened. Patient comes like that. Can we have the photo there if somebody hasn't? So how would you proceed with that case, Rahman?
So I think
Injections, vitrectomy, what would you do?
well, again, I would try and start with injections, depending on the situation of the eye. But when you move from post-cataract to bleb-related to traumatic endophthalmitis, these are the severest. And,
Yes.
you kind of tell the patient with trauma, particularly with the foreign body, there's a 1 in 10 chance of developing endophthalmitis. And usually it's not just one thing, there may be something else. There may be a foreign body, there may be traumatic detachment and things like that. So you really have to explain, and the visual potential is not very high. So you have to counsel the patient, and usually it's the family because these are kids. So you have to explain
Usually
to
they are
them,
young people, get trauma, So your take would be first injections you would like to
I would
try.
again, because one of the reasons is that if they are kids, you really want the vitreous to separate before you actually take them to OR. So, you treat them with injections until the vitreous separates, and then you take them to OR.
Yes. What about you, Ahmed?
The issue in these cases is that the cornea worsen quickly. So if you inject them, what about the cornea? Usually it worsens very quickly. That's why I proceed with vitrectomy.
So you would go for vitrectomy earlier in trauma cases?
In this case, with a good cornea, I will go. I want to go with vitrectomy with this good cornea.
Gustavo, what about you?
Lose a good cornea.
Traumatic endophthalmitis. Would you inject first or would you go for vitrectomy?
So that's a very good question because this is very seasonal here. Since the region where we live, we have a lot of people who still work on the field, on the rural area, okay? April is the month of traumatic cases, eye traumas, because they start to chop wood for the winter, which in the southern hemisphere is in June and July, okay? So, and it's almost automatically here. In these cases, vitrectomy for sure.
So vitrectomy you would go for, yeah, okay.
So I would just like to add a comment. I had a patient with traumatic endophthalmitis. He presented with counting finger with blunt trauma, traumatic related cataract, and very bad endophthalmitis. What I did was, instead of, because he couldn't go to bigger cities because of the financial conditions, I started giving him intravitreal antibiotics along with DEXA. I really gave him frequent DEXA, and then I did the cataract on him, and his vision improved from counting finger to 612, and he's doing really well now. So he didn't need vitrectomy.
Okay, but most of these cases have fungal endophthalmitis. So a large number of traumatic cases have fungal. So I am worried to inject dexamethasone in the presence of fungal infection.
Yeah.
So if I going to inject, I will inject.
I think cause is also important.
Yeah, cause is important. Here it was blunt trauma, so I wasn't being suspicious of the fungal one.
So coming to preventing endophthalmitis.
Just a comment on that, on traumatic, any trauma basically is that they just remember the eyes are stuck to the body and not the other way around, is to make sure that look for sympathetic ophthalmia as well. It's rare, but you will get it. If you're not careful. I've seen a couple in Pakistan before I left for UK, and you will get it. So important, and other thing is tetanus prophylaxis as well. See, that's important as well.
Dr. Tariq, prevention of endophthalmitis in cataract surgery, what precaution do you take? Or in your practice, what do you do to prevent endophthalmitis?
Before cataract surgery, we don't give any antibiotic, but the theater preparation is most crucial. We always give local anesthesia. We make sure, if we are doing under the tropical anesthesia, we make sure the bottle is clean. It hasn't been used in any other patient in the OPD or elsewhere. It should stay in the theater, number one. Number two, a proper cleaning of 5% pyridine iodine is more than enough if you can do it properly. But in my experience, by mistake, we have using 10% pyridine iodine. It doesn't happen to the eye anything. Even we have seen it is more safe than 5%. You can use it. And
so you're using 5% pyridine to clean it, yeah?
Yeah.
Okay. You mix it and
by mistake, we have used 10% as well. It also works as good as 5%, doesn't matter. But you can make your own 5% with the 50-50 solution with BSS you can put in, which is pyridine jo aati hai yahan pe. The thing is that with proper cleaning and make sure that your lid examination, the anterior marginal disease, lid disease is there or not, that is very crucial before you book the patient for the list. These are the important steps. If you do this properly, if you put a proper drape on it, the lashes are covered, proper handling of the speculum, I think you are safe. If you're not doing these following things, you are in trouble.
Dr. Safdar, anything you want to add more, or?
Yeah,
is it 5% do you use or 10%?
Yeah, we use 5%.
5%.
A couple of my colleagues do a bit of a periocular scrub with 10%.
I think periocular usually I use 10%.
Yeah, but I wouldn't
internally
use
in SAC I use 5%.
Yeah, I think it's a bit, so it's a bit 5% nicer to the cornea in some ways, you know. So I think the battle is really won before the day of the operation. That's the absolute key to preventing. We can't prevent it 100%, but as I said, we have not had an issue since 2008. And now there's a wood to touch here. You know, you never know what happens when you go back. I think the key bit is we do run pre-op assessment clinics over there, which we always encourage our registrars to do. I found it very useful. I trained for 4 years in Northwest, and I did that sort of twice a week. is to pick out those high-risk patients or immunocompromised patients that you think are likely going to go that route. I think that's an important bit, especially with ocular surface disease, as Professor Saab has mentioned. That's important. You know, aggressive diabetes, all the other stuff that can make that's really important. You've got patients with rheumatoid arthritis, immunosuppressants, so all these little things are important. If you know there's a complex case, don't give it to your registrar you don't like, try to do it yourself. These sort of little things do matter. And then obviously on the day of the operation, meticulous prep and PVRS and all of that use. Since we have shifted to intracameral use, we've not had any issues really. So
I think that was one of the turning point, isn't it?
Yeah, it was the SCRIS study by Peter Berry and Pierre Montan. I think that they did in 2008. It came out in 2007 and then completely changed everything. But that was the combination of 5% PVRS with intracameral cefuroxime. If your patients say they're really allergic to or hypersensitive to penicillins or cephalosporins, then you can try vancomycin. We use vancomycin, but I think USA moxifloxacin is used as well.
We are using moxifloxacin.
So there's some people actually use a combination of cefuroxime and ampicillin as well. All sort of the only thing with vancomycin is you inject it inside the eye, the cornea goes completely hazy. So don't get too alarmed by that. It just goes away after half an hour. So.
Dr. Ahmed, what about you? Sorry.
For me, for cataract surgery, I think one of the most important factors for endophthalmitis is the leaky incision. So I spend a lot of time at the end of the surgery, make sure that my incision is tight, and I have very low threshold for placing a suture. I'm not shy at all to place a suture in the incision.
I think it's very important that your wound shouldn't be leaking. So
yes.
And I think that was the reason even when 25 and 27 gauge vitrectomies were coming initially, there were a lot of cases of endophthalmitis because not the wounds were leaking, there was infection. So wound construction is important and closure is important. Yeah. Rahman, sorry, Dr. Tariq, you want to add something?
Yes, I just wanted to ask one question to Safdar. इनसे हमारी जंग चलती रहती है अपने फोरम पे. You mentioned about the diabetes thing. In Pakistan, the Rahman has published a very good article about the incidence of Pakistani diabetes, which is a very alarming pictures. Every other third patient is a diabetic in our society. And किसी की भी sugar control नहीं होती, If we do the HbA1c, किसी का 8 है, किसी का 9 है. So in my experience, we don't consider diabetes as a major factor in endophthalmitis. यहाँ पे every other patient is a diabetic. And you said that diabetes consideration, it surprises me.
I think it's, I deal with diabetes all the time, every day. I think it's, the diabetics were really 20-22 millimoles per above. I think that's the one that you need to target. I think the Royal College guideline is probably going to be changing next year on this as well, because there's a lot of confusion regarding the nurses are sticking in needles every time the patient comes in. So we have a threshold of about 20 on the day, but if the hemoglobin A1c has been quite poor over the previous few months, that patient is at a slightly higher risk. What I do is I tend to operate on them myself rather than offer them to my registrars or as a training case. So I think that's what I tend to do. But you're absolutely right about that. Diabetes itself per se is not a huge issue, but really these are bad uncontrolled diabetics who are really spiking very high. They're the ones to be worried about. The other thing is they've got comorbidities. They're going to have other issues. Renal problem is very common with them, liver problems. I've seen a lot of case mixture. The ones we have actually gone bad, if you look back at them, there's always a bit of an element of comorbidity that you pick out from these cases.
Gustavo, what do you use as intracameral antibiotic? Moxifloxacin or cefuroxime? What do you use?
Endophthalmitis is a so serious condition, okay, that when our fellows start doing their program here with us, the first presentation, the first lecture, the first thing we teach them, it's about how to properly prepare an eye for an eye surgery, okay? So 10% iodine for the periocular and 5% for the eye drop for the surface, okay? And since we had the paper that came out that the number was 2 million or 5 million eyes showing how safe moxifloxacin is intracamerular, we are using at the end of each phaco, we are injecting moxifloxacin. One issue about the comorbidities we were talking about, for me, the worst scenario is always diabetes. In my whole life, I had 2 cases of endophthalmitis after vitrectomy, okay? One was a patient which had his HbA1c, it was like 14%. He already had kidney problems, whatever. And the other patient had endophthalmitis after oil removal. That's something we are still registering. I don't know if any one of you have ever heard about it, but I was super disappointed because it was a very difficult retinal detachment. I could reattach the retina, I used silicone oil. We waited like 4 months to remove it. And the day before the removal, he came with a super endophthalmitis, which evolved to phthisis. So it's an issue, but for general cases, phaco, if you are talking moxifloxacin, 0.1 pure at the end of the surgery, 0.1 cc.
Yep, okay. Any, Zubeda?
So I'm not sure what is the consensus on intracameral ceftriaxone versus moxifloxacin, but I just came across this paper that is being done at Aravind Eye Hospital, India. It's an ongoing study on like 2 million eyes, and they have seen very promising results with intracameral moxifloxacin. Yeah. I myself use intracameral ceftriaxone.
Yeah, it's pretty safe, yeah. Dr. Shakib, you want to add something? Or?
It's the, I give, for cataract patients also, I give prophylactically, I do give oral antibiotics.
आपके शेयर है लगता है अब तो साबित हो गया अब तो
I haven't definitely
stock market आपकी वजह से ऊपर जा रही है.
exactly it's because of
Shakib
that.
has got share in the company.
But on the other side, I kill them because then I don't have to use later on a lot of antibiotics, because if you do in Pakistan setting, it's always good because you never know they are harboring some infection somewhere or not. We can't test them, but somehow I do it. Yeah. It's my habit to a day before, on the day of surgery, and day after.
आपकी सारी antibiotic छुपा देंगे हम.
Yeah, exactly. And same before the surgery, I don't start antibiotics a few days earlier, but on the day of the surgery, for about 10, 20 or 15 minutes, when the patient is waiting for the first patient to come out of the theater, at that time 15, 20 minutes antibiotic drops every 5, 6 minutes. So that gives a good concentration in the anterior chamber and in the sac. So alhamdulillah, it's going good.
Endophthalmitis is a huge topic. I think still a lot of things to, but I think I want 5 minutes to give to Dr. Tariq for his talk, so I'll just skip these things. I think mostly we have discussed about vitrectomy early later, so I'll leave the videos as well. So yeah, so just they were. Dr. Tariq, you want to comment?
This is a very interesting presentation, not offending anybody. Its topic is dealing with endophthalmitis. हो सकता है कुछ लोग offend हो इस presentation से, and post of endophthalmitis. Okay, no problem. Okay, that's what. Indeed, it's the most feared complication, but if referred to you, do not blame him or her. यहाँ पे the most common thing is that if you refer this patient to another doctor, and the doctor will look at the endophthalmitis eye on the slit lamp, oh, you know, although he's not saying anything, but that oh word, doctor साहब मेरी आँख खराब हो गई, you know, that sort of a thing. One has to be very careful. Seek an opinion of colleague who you better equipped. Do not get irritated with the patient. If you think whoever you refer to a VR surgeon, make sure that he knows his job very well, particularly in this situation, endophthalmitis thing. And do not get irritated with the patient, because once endophthalmitis will have it, patient will ask you thousands and thousands of questions. No doubt about that. Keep all patient fully informed. Pessimism is better than unrealistic optimism. Refer to the VR surgeon you trust. The main thing is trust. I'm not offending any VR surgeon here. The thing is that make sure that you're referring to the patient, oh, तुम्हारी तो आँख खराब कर दी इस आदमी ने. You know, the cataract surgery done in this part of the world, and no, I said don't be offended. You know, the VR surgeon ko thoda sa pinch hoga, no doubt. And refer to the VR surgeon you trust, because
ओहो syndrome है ये.
and the thing is that the VR surgeon should be better equipped to deal with this situation, because you're dealing with the vision, you're saving the eye, wanted to save the eye. If endophthalmitis happened, please don't charge additional fee on every visit. Okay? And refund the amount of IOL surgery if you have done it, because disaster can happen to anybody, although it's very rare. Because in this part of the world, in Asia and in India, Pakistan, Sri Lanka, the cataract surgery is the most common surgery done, and the complications will happen. VR procedure required cost. If you can waive it, or if the concerned surgeon can waive it, it will be a blessing, but it looks very highly unlikely. Express empathy with your endophthalmitis patient. Always talk to the patient. Please talk to the patient. Don't avoid the patient. Understand his or her frustration and fear. कि मेरी आँख चली गई, मुझे तो पहले तो मैं कुरान शरीफ पढ़ लेता था. I can read the letter, I can read the newspaper headlines. Now I can't read anything. To spend time with the patients. Don't get irritated. He will come to your OPD and he's sitting outside your OPD room every day or every week. Doctor Sahab, meri to aankh theek nahi ho rahi. That sort of a thing. Provide comfort, hope, but no false hope. If you think the eye is gone, better tell them. You're not going to see ever again. Because don't drag the patient again and again. Acha chain drop badal diya, agle hafte aana, nahi aana. Don't give any false hope. Stay calm. Stay calm. Give them as much information as possible. Do not get irritated. I am saying again and again to you. Calling you at odd times, because whoever's got endophthalmitis, he might call his friend somewhere in America. You might be sleeping at that time, and you might be receiving call at that time because of the time difference. Receive the call. Don't get irritated. Consistency is very important. These are the common questions the endophthalmitis patient will ask you. How, why, what can I do? You have to answer it. Be calm. How did this happen to my eye? What are the chances of visual recovery? Can you remove my eye? So these are the questions. You have to answer it very carefully. Be sympathetic. Don't get irritated. Endophthalmitis, as we have all discussed with the wonderful discussion we had, and the moderator, Dr. You have conducted a wonderful session, no doubt about it. It's a very, very rare thing all over the world, and it's a serious matter, and it's a proper strategy with sensitive management. It is possible to emerge with your head held up and reputation untarnished. You have to be very careful. Thank you very much. Last thing I wanted to take 2 minutes. Medical Retina Association of Pakistan always give the leadership award to one of the budding people in medical retina. Hina Khan has received already this award from us, and today we are giving another award from our overseas member of our group, Dr. Safdar Raja, for his leadership qualities in the medical retina. Can I ask our sitting president of Medical Retina Association of Pakistan, Dr. Shakib Anwar, to present this award to Raja Safdar?
Right. Just a comment, a couple of comments there. Thank you very much for the honor. Somebody has said budding after a very long time, so that's not I'm not gonna. Budding is young. The other thing is you put the rate of endophthalmitis as 1 in a 1300 to 1 in a 1700. I think it's a bit better than that, depending upon the cause. So, thank you.
आप साथ जाएं तो वो बडिंग लगेगा.
question or anything? Somebody wants